Hello. Hello, can you hear me?
Yes, sir.
Hello. Hello, can you hear me?
Yes, sir.
Okay. What is happening? Is anybody there?
Sir, the class is from 3 p.m. I think they will come within 3 or 4 minutes.
All right. Okay. Okay. That's all right. I think I'm a bit earlier, or yeah, maybe.
Sir, you are on the right time, but all the other teachers give 3 or 4, 5 minutes for the target.
Also, they are on the other class. Arekta class আছে তারা?
স্যার আজকে আপনার শুধু বিকেল বেলা
Okay, that's fine.
শুক্রবার তো নামাজ টামাজ শেষ করে একটু রেস্ট নিয়ে 4-5 মিনিট বা 10 মিনিট অনেক সময় টাইম দেয় স্যার ম্যাডাম।
Okay. ঠিক আছে।
শিডিউলড ক্লাস স্যার 3টা থেকে।
হ্যাঁ, সেটাই আমি, কারণ আমার টাইমটা এভাবে আমি করছি, কারণ আমার এরপরে আবার একটা ক্লিনিক আছে।
ওকে স্যার।
আমি টাইম টেবিল করতে যাই না। এনিওয়ে,
জি স্যার।
I'll wait for them.
স্যার আর 5 মিনিট পরেই শুরু করি।
No problem. ঠিক আছে,
Okay, sir.
কোনো অসুবিধা নাই। Thank you.
So you can start the lecture. Hello. হ্যালো, স্যার কোথায় গেল?
স্যার তো বললো আবার স্যারের পরে আরেকটা নাকি ক্লাস আছে ওই রিলেটেড
হ্যাঁ।
বা কোনো কিছু অ্যারেঞ্জ করতে গেল কি
আমাকে তো হোয়াটসঅ্যাপে লিখছি বাট কিন্তু আসতেছে না।
Hello.
Hello, sir. Please class start করে দেন, sir.
Right. Should we start?
Yes, sir.
Okay. Okay. So, have you got the slides? Okay, I can have my slide. I have got my slides here. Just give me a second, please. Yeah. So thank you for coming to the session. My name is Dr. Amal Paul. I'm a GP and I am one of the ICV board member in Leeds. Today, we are going to talk about erectile dysfunction and premature ejaculation. What I'm planning to do to have this, I've got a few slides. There's a number of slides. You will get a copy of the slides, so don't worry to make any notes or anything. And there will be few slides which are quite elaborative. It may be that you take a note of it only, visual note, and just listen what we are discussing. And when you will get a PDF form of these slides, you'll know what we talked about. And if any question, you can contact Rifat or me. We'll discuss further. Today, I'm just planning to give you some basic information, not in detail, basic information as what we need to know as a primary care physician or GPs when a patient comes to us to discuss their problem, especially the sexual inability, which we often call erectile dysfunction, and loss of libido, that is, erectile dysfunction and premature ejaculation. These are the two things we can talk about. But loss of libido sometimes comes under the heading of erectile dysfunction. So this could be quite complex, but we'll try to stick to our headline on erectile dysfunction and premature ejaculation. My aim will be in the next 1 hour to give you some flavor how we will assess a case or a patient when they come for erectile dysfunction or premature ejaculation, to see or assess the background risk factors, how to assess them and how to treat them and how to make their arrangement for follow-ups. Most important thing which I would like you to understand, that you would also understand the reasons or the circumstances when you should refer a patient to the secondary care. It's very important that we understand our limit as a primary care physicians or GPs to treat a patient and then to advise them to ask for secondary care, that is the consultant's advice. I understand that the system is not very well developed in Bangladesh, but you always can send or advise your patient to see a consultant in the clinics or somewhere. It does not mean that you have to make a formal referral, but you need to advise the patient. So if we talk about the erectile dysfunction and what is the definition, this is a persistent inability to attain and maintain an erection, penile erection, sufficient to permit satisfactory sexual performance. This is a bit arbitrary. Some people, they say, what do you mean by persistent? What do you mean by maintain of erection? This is all theoretical discussion, but we need to stick to the point that a patient comes to see us with a complaint that I cannot have a penile erection to make a sexual intercourse. This is the point when we start to discuss and think about erectile dysfunction. This is not a new issue. Erectile dysfunction is not a new issue. It is old problem, and if you have interest in history, then you can see that erectile dysfunction was described about 2000 BC, that is nearly 2000 years before Christ was born. And they defined his erectile dysfunction as two types: as a natural, that is, there is inability to have an erection because of the problem with the penis or the sexual organ, and the other one called the supernatural, that is evil charms and spells. At the time, they believed that there is some evil, and these evils can harm your sexual disease or sexual desire. Hippocrates described his excessive horseback as the background cause of erectile dysfunction, and Aristotle thought there is
স্যার
a
স্ক্রিনটা দেখা যাচ্ছে না।
দেখা যাচ্ছে না?
না স্যার, স্ক্রিনটা শেয়ার হয় নাই।
Oh, then can you share it then, please?
স্যার আমি এখান থেকে শেয়ার করলে স্যার আমাকে কন্ট্রোল করতে হবে। আপনি কি কন্ট্রোল করবেন না আমি দেখাই? আমি
You can control it, don't worry.
ওকে স্যার, তাহলে আমাকে একটু বলে দেন, নেক্সট স্লাইড বা এই ধরনের বলে দেন।
Yeah, I will. Thank you. হ্যাঁ, বলবো আপনি। I'm sorry, I'm absolutely sharing that one.
স্যার চাইলে আপনি নিজেও শেয়ার করতে পারেন।
Okay. Now, can you tell me how to do that, please?
স্যার
Again.
নিচে যে শেয়ার স্ক্রিন আছে সবুজ রঙের একটা, স্যার পেয়েছেন?
No, just should I go back to share screen, huh?
হ্যাঁ ওখানে ক্লিক করেন।
Uh-huh.
স্যার ওই যে আপনার স্ক্রিন স্লাইডটা দেখাচ্ছে মনে হয়। হ্যাঁ ওটাতে ক্লিক করলে চলে আসবে। হ্যাঁ স্যার চলে আসছে।
দেখা যায়?
হ্যাঁ স্যার, এটা এখন জাস্ট আপনি যে ফ্রন্ট আর ব্যাকে যে আপনি স্লাইড অনুযায়ী যে পড়াচ্ছেন ওইভাবে গেলে আপনি যেতে পারবেন।
এখন দেখতে পাচ্ছেন?
হ্যাঁ হ্যাঁ সবাই দেখতে পাচ্ছে এখন।
Oh, good. Thank you. Should I go back to fast, or can you see that now?
আপনারা কি দেখতে পাচ্ছেন?
স্যার ক্লিয়ার দেখতে পাচ্ছি স্যার, আপনি এখান থেকে কন্টিনিউ করেন স্যার প্লিজ স্যার।
আপনি কোথায় আপনারা erectile dysfunction definition দেখতে পাচ্ছেন?
জি স্যার দেখতে পাচ্ছি স্যার, ডেফিনেশন অফ erectile dysfunction.
Good. And erectile dysfunction first described in 2000 BC.
জি স্যার ক্লিয়ার দেখা যাচ্ছে।
Oh, good. Thank you. So, okay. So we should continue from there now. Basically, so we talked about that some historical aspects. It's very brief thing, but now even after 4,000 years, still people are coming to us with the problem of erectile dysfunction. Newly married, mid-age, or elderly people, they have the incidence and prevalence of erectile dysfunction, that is, they are failing to have adequate sexual activities. One thing you need to understand, that erectile dysfunction is not a disease, but it is a symptom. Okay, so like fever is a symptom of malaria. Malaria is a disease and fever is a symptom. Exactly that. The erectile dysfunction is a symptom, not a disease. There must be some reason behind this erectile dysfunction problem. So we should not jump to a conclusion that this is a disease, and we should not treat it as a disease until unless we find out the underlying cause. So why people can have erectile dysfunction? That if you go back, and we'll come to that how erectile dysfunction occurs, then you will know that it could be organic, that is, there is a problem with the external genitalia. Psychogenic, that is, the person is not ready for the sexual activities due to any reason, or they are not engaged, or they have some hesitation. And third cause is mixed. There is some person have organic problem, that is problem with the external genital, and at the same time they have anxiety or stress, and then it gives the problem for erectile dysfunction. Sometimes we call this primary organic, sometimes you call the mixed etiology, but whatever you call, you just keep in mind that either it could be related to the external genitalia, or it could be the anxiety or stress, or the combination of these two. Now, if we go back to just a very brief etiology, how it happens, if you have some source of stimulation, either in the brain or tactile stimulation, it affects the neurovascular system. There is a neurotransmitter from the brain. It affects the blood supply of the penis. There is increased blood flow to the penis and a reduced return. And that gives the penis full of blood, and that gives the erection. This is again just a brief cross-section of the penis when it is flaccid and when it's erection. You can see the basic difference is lots of blood arterioles there with full of blood, and here when the flaccid there's a less blood. And also when the flaccid, the vein is fully open, so if the blood is coming to the penis, is going back. But when there's erection, the blood is, lots of blood is coming to the penis, but the vein is constricted, so there's a less return. So there is a retention of blood in the penis, and that it have the erection. If you can remember this, we will go when we treat, it will be easier for us to discuss things. Now, just again, very briefly, how it happens. A person, a male can have visual, tactile, olfactory, or imaginative of a act of sex. The brain and the spinal cord, the response with release of some chemicals, neurotransmitters. It affects the pineal structures, increasing the blood supply, and there is erection. Now, why? This slide just shows why there is a problem with erection. Number one, lack of intimacy. When they go for sexual performance or sexual act, if the intimacy is not as it should be, then emotional, social, sexual, intellectual, or recreational impact on our intimacy, then it's reduced your trust, and then it becomes a unloving, unloved situation, giving rise the lack of neurotransmitter released from the brain, and hence the lack of blood supply to the penis, and that flaccidity that leads to erectile dysfunction. Now, if we go back to our initial physiology of erectile erection, that we saw that the blood supply to the penis is increased during the erection. So if there is any problem with the blood supply, either in the vascularity or due to flow of the blood in general, due to the vasoconstriction, or due to reduced the arterial supply to the penis, it can affect the erection, that is sexual dysfunction, erectile dysfunction. Like as for example, in diabetes, cardiovascular disease, smoking, they reduce the blood supply all over the body, and hence there will be reduced blood supply to the penis. Smoking is one of the major factors. Barger's disease, which affects the leg, and there's a lot of amputation in our country. This is one of the vascular disease associated with smoking that can equally affect the sexual function. Major pelvic surgery, radical prostatectomy, and another one is post-radiotherapy. Those of you who have treated any patient with prostate cancer who had radiotherapy, you will note that they have sexual dysfunction, that is erectile dysfunction, and it is related to the blood supply to the penis, due to the vascular problem or due to flow. And in neurological, like if it is multiple sclerosis, Parkinson's disease, peripheral blood supply problem, like as I mentioned, diabetes, post-surgical, like pelvic surgery. If somebody is having bladder cancer or prostate cancer, they have pelvic clearance or major pelvic surgery, then the blood vessels and the nerves are affected. And that gives rise to the inadequate blood supply to the penis and hence the erection. Please don't make a note of it. I'll send a copy of it to you so you will get all these causes. The another factor is hormonal. If there's a hypopituitarism, thyroid problem, and multiple endocrine disorders, that can equally give the problem with erection. Now, we started with the organic cause, that is the genitalia cause. If the person has congenital curvature of the penis problem, micropenis, hypospadiasis, or peyronie's disease, pineal cancer, these people may have erectile dysfunction. Now, at this point, I think we have at least we try to understand what are the causes of erectile dysfunction, that is organic, psychogenic, and the mixed. An organic one is the problem with the penis or external genitalia. Psychogenic, we discussed that if somebody having diabetes, depression, lack of tactile or other emotional problems that can, and the mixture of these two. Most probably we will be confused whether the other diseases we mentioned which are giving the problem with erectile dysfunction, whether it should be organic or psychogenic. I think it should be mixed. It should not be a completely different criteria, but it should be a mixed. It should be classified as a mixed one in between the part of the organic, because the lack of blood supply, part of psychological. Now, how the diagnosis is made, or what is the basis of diagnosis? First thing is, as we always know in medicine, that the good history taking, and there is nothing important in detailed history taking than anything else. You may or may not need any investigation, but it depends whether history taking is adequate and you understand the background risks of this erectile dysfunction. So as we do the general medical, psychological, sexual, and medications. These are the 4 primary headings you need to explore. Then you go for the examination. You please don't forget to examine the patient. In my experience, we have patients who had inadequate examination, general examinations, and genital examination. A potentially disastrous pathology was missed. So I will urge you to be careful and always undertake the general physical examination and the genital examination. When you have taken the history, did the examinations, the next step in our basic medical school learning to do some investigations and make some observations. We say observations which we include blood pressure, pulse, weight, height, so and so. However, because of the widespread incidence of erectile dysfunction and some organic medical problem like diabetes, thyroid problem, and hormonal problem, it could be a good reason to undertake the basic tests like here you call it full blood count. I think in Bangladesh we call it CBC or CBC. Do that, do the diabetes test, HbA1c, thyroid test, TFTs, and hormones, especially the testosterone, FSH, LH. FSH and LH are the important thing if there is any doubt that there is a primary hypogonadism. And testosterone also very important, again, to diagnose hypogonadism and as well as some drug abuse. So these things you should do. Prolactin, you can do it, but if you don't want, that's fine. One other thing I must say, this you should do, that is PSA, prostate specific antigen. It's, if you do one test, please do PSA, because erectile dysfunction may be the first sign of prostate cancer. And I'm not sure how far you are aware. The worldwide, there is a research, and it has been now documented that the Asian peoples and the Black Afro-Caribbeans, they are higher risk of having prostate cancer and the early onset as well. I have seen a patient to have prostate cancer as young as 32 years old. So if a patient is presenting to you with erectile dysfunction, you must do the PSA to exclude the possibility of prostate cancer. And also undertake the CVD screening. You may do the chest X-ray, ECG, or whatever you want to do. Maybe cholesterol checks you should have in your mind. And you should tailor-made according to the presentation of the patient. But try to avoid the over investigations. Now there is a couple of things I have mentioned in the erectile dysfunction treatment. The first thing is counseling and information. There is no replacement of this first one. Counseling is very, 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 very important, and giving the information. Miss of information or lack of information is one of the cause of erectile dysfunction. Newly married couple, they have little experience of sexuality. They may have unusual experience or expectation, and that can end up with erectile dysfunction. So please take your time, provide them counseling, give them information about erection, about the causes of erection and how they can resolve it. Find out if there is any underlying cause, especially the anxiety or depression. Then you come to medication if you need. The medication will be first, if there is an underlying cause, treat the underlying cause. If, as for example, there is a poorly controlled diabetes, try to manage the diabetes, make it control better. If there is a heart problem, do it. Another thing is there is a medicine. There's a whole lot of medicine which can give the erectile dysfunction. And please go back to the medicine list, talk to the patient, try and see whether there are some medicines which are going to give them the side effects. Even you can see simply Ramipril, which is widely used, can give erectile dysfunction. This is one of the common medicine we use in the UK. So that's I'm telling you, try to look into the medication list, whether there is any evidence that one medicine could be the reason for the erection problem. Let me go to the next one. Then medication. You know this, the Viagra is one of the mostly publicized medicine I have ever seen in my career. It is, I think, mostly abused or overused or used medicine, whatever you say, in the world. I think after fluoxetine in America. So Viagra is a medicine which is called is phosphodiesterase 5 inhibitor. This is an enzyme that promotes breakdown of cyclic GMP, which regulates blood flow in the penis. If we go to the next one, so I don't know about in Bangladesh, I'm sure the Viagra you can buy over the counter. We call it sildenafil side tablets. These tablets are miracle care. The people say this is the miracle care for erectile dysfunction. And I would like to give 1 or 2 minutes to let you have some insight. So this is a very overcrowded slide, but if you understand these slides, the measurement of slides, you will understand how the Viagra works. When a person's brain is aroused, signals go to the penis, and there is a release of chemical called cyclic GMP. This chemical relaxes certain muscles in the erectile tissue of the penis and allowing the blood flow to increase. That is, the arterioles in the penis, they have more area to expand and the blood flow is increased. And so there's lots of blood goes into the penis. And at the same time, the return from the venous return is reduced. So there is ejaculation. Sorry, there is erection. And when there is ejaculation, what happens? If the same status quo is there, which happens in priapism, you know that priapism is a condition when the erectile penis refuses to be relaxed. So then what happens after ejaculation? There is an enzyme called PDE5 is released, and that breaks down the cyclic GMP. And when the cyclic GMP is broken down, then the vascular system in the penis and the erectile tissues in the penis, they are relaxed. They allow the blood to get out of the penis quickly, and the supply to the blood to the penis is reduced. So what Viagra does, they inhibit the effect of the PDE5. So if there is a less blood supply, the cyclic GMP, they release that, but the breakdown is reduced by the PDE5. So the effect of the GMP is increased. So there is a lots of time for the penis to have the blood, whatever they have, and the erection is sustained. If the erection was suppose of a minute before, it can be 2 minutes, 3 minutes. But very good thing is this Viagra, the PDE5, inhibitor, they don't work for hours. So after a few minutes, it is hydrolyzed, so it is no more effective on the penis. So there is flaccidity again. So in case if the Viagra, the medicine, the cyclic GMP is still there, then there is a constant or sustained erection of the penis, and that could be a very painful situation. I don't know you have seen any patient with such patient, we call this priapism, that may require hospitalization and sometimes an operative procedures. So why we prescribe a Viagra? That is, we do it in case of erectile dysfunction. That is when the patient complains that the erection is not adequate. But it has got important contraindications like coronary heart disease, angina, GTN spray. If I ask you to understand and remember one point about prescribing Viagra, please and please don't prescribe it to Viagra any patient who has unstable angina, who had coronary heart disease, like he had a myocardial infarction recently, whose blood pressure is not controlled, or who uses GTN spray for control of ischemic heart disease, because that can give a very serious side effects. Even they may die from a sudden heart attack. So this is a one point which I would urge you to remember. Be careful when you prescribe Viagra in patient who had coronary heart disease like angina. You can ask single question: do you use GTN spray or do you have chest pain? And then you can understand what the risk the patient posing for the Viagra. As I said, the risks again are prolonged erection and priapism, which I discussed earlier. There's some side effects like headaches, palpitation, flushings. Another thing you need to counsel when you give Viagra to any patient, and when to take, how to take. Usually it is better to take half an hour to 45 minutes before the intended sexual intercourse. So the person will have time to have mental preparation, and also the body will be prepared for the erection. And you must counsel them about the prolonged erection and priapism. If it happens, they must take the medical advice as soon as possible. Otherwise, it could be a disaster, because there could be necrosis of the penis, and they might need a penile excision. This just again gist, but a little bit more. Side effects of Viagra, like cardiovascular, which is explained, prolonged erection and priapism, effects on eye dryness, eye, hearing loss. It's not common, but it can happen. It's not very common. Alpha blocker, you should not use with alpha blocker because it can increase the side effects, especially they feel dizzy and loss of balance. Adverse reactions with use of ritonavir. This is one of the things you should remember, because of now we use lots of antiviral medicine. It's not common to use that ritonavir in the population, but just ask them, please. Please do not use combined PDA5 like some people with Cialis and Viagra together. Is not safe to do that. What you can do, when you prescribe Viagra, you can start with a low dose of 50 milligram, then you go to the full dose of 100 milligram. If it does not work, you can change it to Cialis. Cialis, you can use in a couple of doses. One of them is 20 milligram is the full dose, or 10 milligram to start in the low dose. Some people, they prefer to use 5 milligram daily. But if it is 10 milligram or 20 milligram, usually the recommendation is you should not use more than 2 times a week. But 5 milligram you can use every day. Another important thing for us to remind the patient why they use the Viagra, what is their intention. Some people, they can use or do use Viagra for recreational purpose, to have sexual activities outside the marriage, or they have random sexual partners. So you must counsel them the risk of sexually transmitted diseases which are associated with the use of Viagra, not as part of the side effects of the Viagra, but it is because of the irresponsible or reckless behavior in having sexual intercourse. These few things I just want to tell you. This is not in our arena as a primary care physician. People can use the vacuum pump for the erection of the penis. They can put a suppository inside the urethra to have the erection. And also there is another one, is the implant. It is really not within our arena as a primary care physician, but if you want to make a note, you can note that there is some other ways to help the people with erectile dysfunction that is other than the medicine. And the self-injection, there's many people, they inject in the penis some stimulant which constricts the venous outflow and increase the arterial flow. So there is engorgement of the blood in the penis, and they work locally. But the erection, but the painful procedure of injecting is the side, I would say this is the most concern for the user, because that can give a risk of infection. So if we conclude what we have learned, that erectile dysfunction is a symptom rather than a disease. It may be the very first sign of prostate cancer, so blood for PSA must be done. We should initiate treatment after having full medical history, sexual history, social history, performing a thorough examination, general examination, and genital examination. If we think there is no organic lesion there, you can prescribe PDE5, that is Viagra. I think this is the most suitable one. And when you prescribe the Viagra, you must make sure that you organize follow-ups with the patient. I understand it's not easy in our country, but at least you can advise the patient to see you maybe once a month, once a 3 months, or once a 6 months, as you think is necessary. If you have any doubt about managing a patient with erectile dysfunction, please do not hesitate to refer them to a urologist who can assess better and provide better medication and management. So this is my first part, end of my first part. Do you have any question to ask? Otherwise, I will go to premature ejaculation. Anybody has any question?
আর আদাব স্যার, আমি ডাক্তার নজরুল বলছিলাম।
হ্যাঁ বলেন প্লিজ।
স্যার ইরেকটাইল ডিসফাংশনে ইনভেস্টিগেশনে ভাস্কুলার ডপলার করার প্রয়োজন আছে কিনা?
ভাস্কুলার ডপলার করার প্রয়োজন আছে কিনা, ইটস এ গুড কোশ্চেন। আপনি ভাস্কুলার ডপলার কেন করবেন? কোশ্চেন এটা, আপনার ডাক্তার হিসেবে যদি আপনি নিজেকে প্রশ্ন করেন যে ভাস্কুলার ডপলার আপনি কেন করবেন, কোথাকার ভাস্কুলারিটি আপনি দেখবেন, পেনিসের ভাস্কুলারিটি আপনি দেখা কতটুকু আপনার জন্য ইট উইল হেল্প ইউ টু ম্যানেজ, আই ডোন্ট নো। আপনি একটা কাজ যদি মনে করেন যে there is some compromise of the pelvic blood supply, you can do the pelvic vascular Doppler, but I personally don't think it's a very good idea, but you can do it. There's nothing you can stop it. কিন্তু আপনি যদি মনে করেন আপনি কেন, what prompts you to do the vascular Doppler, এটা যদি আপনি নিজেকে কোশ্চেন করেন এবং যদি মনে করেন যে না there is a reason, যেমন মনে করেন they have a radical prostatic surgery or radical bladder surgery এবং you are not sure what is happening, yes you can do that, yeah, but
Yes.
normally I don't think it is required, but as a clinician আমি
Yes.
এটা সবসময় রেসপেক্ট করি যে as a clinician আপনার একটা রাইট আছে, আপনার you have a clinical acumen to do that, but please don't do that for doing sake.
Yes, thank you.
Anything, anybody? Okay, I'm going to go to the next part, that is premature ejaculation. This is the interesting slide, how a conjugal life can be destroyed if we're not careful to address this issue. It seems to be very innocent problem, but it can cause serious problem in your patient's personal life. So what is premature ejaculation? Let's see what we think the premature ejaculation. The premature ejaculation is the ability or inability of the male partner to ejaculate sooner than he or his partner would like. So if there is a incidence of sexual intercourse and the male ejaculation happens before the person, the male or their partner expected the ejaculation, the reason is, you know that after ejaculation the penis become flaccid and the sexual intercourse hardly can proceed further. So that is the main reason for the problems we anticipate or we note with premature ejaculation. So what is the time frame? How long a person should wait before they think this is the time we ejaculate, or this time is not good for me or my partner to have the ejaculation? This is really not sure. This is a very variable, and there is not agreed time span either in second or minute when the ejaculation should take place and when the premature ejaculation should be defined. It is individual couples decision, individual couples feeling how they I have a patient who complained of premature ejaculation after having 10 minutes of sexual intercourse, which is I didn't understand, but this is their feeling, and I need to respect them. Second one is how common is premature ejaculation? I'm sure you practice medicine and you have lots of patients. I have lots of patients who complains of premature ejaculation and they're unhappy in their life because of this problem. But as a ballpark figure, 1/3 of the male, they have complaints about the premature ejaculation. And very interestingly, varies from the age to age, and it can happen as young as 16, 18, 20, or middle, not to mention at the end of or the latter part of the sexual life. But it can happen. What I'm trying to make a point that premature ejaculation is not a certain age-related factor. It is a factor which can happen anytime. What usually they say that if a sexual intercourse takes place and the ejaculation happens within 1 minute or just around 1 minute of penetration, they feel that there is a unsatisfactory performance, and they feel the ejaculation took place before even they started to enjoy the sexual performance. What happens then? Then they feel frustrated, and this frustration gives anxiety, and then both of the sexual partners, they feel failure. Male, female, both of them, they feel there is a failure from their part to achieve the enjoyment of sexual intercourse. So that is the reason why premature ejaculation is so common, because sometimes the male is happy, female is unhappy. When the female is unhappy, male is happy. So sometimes it is difficult to come to a conclusion that both of them are happy or not. But why it happens? Why it happens? The premature ejaculation is so common, 1 in 3 couple. One is decreased confidence in relationship. This can happen very beginning of their marriage or co-living, when they hardly know each other. They don't know even their sexuality, the performance, and they feel very frustrated quickly. And there is a lack of confidence as well. Sometimes there is interpersonal difficulties, disharmony in the marriage, disharmony in the family, long trips. Say they move from one part of Bangladesh to other part, and they left their families behind. So they then started to think about their in-laws, and that also gives rise to some interpersonal difficulties. Mental distress, anxiety, anxiety, stress, embarrassment, and depression. These 2 factors are very, very important. When there's a premature ejaculation, the male, they think they are not capable to perform, and they get embarrassed. When they get embarrassed, they feel more anxious. Then it gives to difficulties to communicate with the women, and that leads to lack of confidence in the relationships. And eventually, it may give rise to sustained anxiety and depression. Both of them can cause enormous trouble in the family life. So what may be the causes of premature ejaculation? If you go back to our discussions, we can see that's why. That's one of the reason is the anxiety. One of the reason is misinformation, lack of information. One of the reason is to have a bad experience of having sex. Somebody having sex at the age of 14 or 15, a male, or 11 and 12 of female, they could have a very bad experience, and when they're mature enough to have a married life, that bad experience reflects on their mind, and they have the anxiety, stress, and leads to the premature ejaculation, sometimes sexual dysfunction, including erectile dysfunction. Sexual abuse is one of the reasons. Many women they're sexually abused in their early life, 14, 16, 12, even 8, 10 years old. They're sexually abused and they lost their confidence on their own body, the power to control over their own desire, and also they have mistrust among the male people around them and the society. So that give a very bad incidence where leads to premature ejaculation from the male and from the female as well. Poor body image, depression, as I mentioned, and anxiety about premature ejaculation is another factor which perpetuate the problems. They have premature ejaculation, they become more anxious. The performance is again deteriorates and leads to the premature ejaculations. Another thing, there's a guilty feeling to rush through sexual encounters. Sometimes the people have first experience of sexual intercourse in a very unusual situation. They perform the intercourse, and that has to be done very quickly because of circumstances, and they ejaculate early. And they think that is the norm. They get this bad feeling in their mind, which comes back when they have their normal married life. So this one, I'm trying to tell you one thing, that's premature ejaculation may have mostly the underlying causes of depression, anxiety, misinformation, or lack of information. Apart from the anxiety and stress, there is some causes, biological causes, why they can have the premature ejaculation. One of them is abnormal hormone levels, maybe low in testosterone, which leads to lack of erection and also premature ejaculation. Abnormal levels of neurotransmitters, inflammation and infection of the prostate. If there is a prostate infection or inflammation, there is some pain when they have intercourse, and that leads to inadequate performance and early ejaculation. And it is not common, but it could be inherited traits. It's very clumsy, complex area. If you found a person who has family history of premature ejaculation, then you need to carefully have a discussion with them whether they need some genetic counseling or genetic tests. But as I said, it's not common, and I think we should be very, very careful even to consider this. What are the risk factors? As I said, erectile dysfunction. If there's a problem with erection, premature ejaculation usually happens. Anxiety about sex and performance, which with the bad early sexual experience, or sexual abuse, relationship problems when there is a marital disharmony, or extramarital affairs. Old age is quietly understandable when the people are aged at 70, 80, their performance is reduced, erection is problem, then ejaculation is problem as well. And also having the problem with the partners. This is very common. If there's a disparity in the age, some people at the age of 70 marries women at the age of 20 or 25, then the disparity of the age, they have different type of expectation and performance that leads to anxiety, stress, erectile dysfunction, and not to mention the premature ejaculation. Again, this is the history. Premature ejaculation, you must take a history with time. You need to go every bit, how, when, what happened, how it started, why it started, and these two important information you to gather from them, and you might get a clue to the underlying cause, and you can treat adequately. Do the blood and other tests if necessary. If you think there is something you need to know, or a mixture of premature ejaculation and erectile dysfunction, you do the blood test. Otherwise, really, blood tests are not, and other tests is not very important. But important is taking history and doing the examination, including the external genitalia examination. Please make sure that we do not forget the basic teaching of our medical student life, that history, examination, investigation, diagnosis, treatment. So how we manage that? Premature ejaculation is extremely difficult to treat. Again, it's easy to treat. This is a two version with the one breath, I can tell you. If you understand the anxiety, stress, if you give time to explain, provide some psychological therapy, they behave in their sexual life, you believe me, they have dramatic improvement in their performance. Sometimes you do the Kegel exercise to holding your pelvic muscle exercise to increase the tone, which many people believe that it increases the ability to delay the ejaculation, but it is controversial, but there is no harm in trying. It is just a simple exercise and people can do it anytime, anywhere. Another thing is condoms. This is one of the things you can really consider, because in the glans penis, there is some sensitivity and neurotransmitter like receptors there. And when they come in contact with the vaginal mucosa, or there is a female orgasm, then these glans penis cells get stimulated and the ejaculation follows. So if the people use the condoms, this direct skin-to-skin contact is reduced, and these neurotransmitters are not released as they are. That can prolong the sexual performance. It may not be the best thing for the couple, but it could be one of the way they can compromise their sexual unhappiness. Many people, they use SSRI, Viagra, and local anesthetics. It's entirely up to you. If you think the patient is depressed, SSRI could be helpful, but I can tell you one thing, sometimes SSRI are the reason for premature ejaculation and erectile dysfunction. So you have to balance it. As I say, Viagra or Cialis could be used in case of premature ejaculation. I have seen patients who are treated with Cialis 5 milligram daily. They have a good response, both in terms of erection and ejaculation, delaying ejaculation, that you can try. Local anesthetics, to apply local anesthetic on the penis, again, to reduce the sensitivity of the glans penis, can be used, but to be careful not to have the local allergic reaction. And you can combine of the above methods, that is, you advise, you give psychological therapy, you advise to do the pelvic floor exercise like Kegels, you advise to use condoms, and sometimes you can give Cialis 5 milligram daily in a low dose to try. All will be on you after the assessment of the patient. The potential future treatment, can I tell you for the beginning, I think as a primary care physician, we should stay away from that. That is a bit complicated medicines and their potential side effects. And this medicine may not be licensed to use, like dapaxetin and silodosin. One of my patients, they came from Bangladesh and they were asking me for prescribing dapaxetin for premature ejaculation, but this medicine is not licensed to prescribe in the UK. I explained to them they're not very happy, and they got it from Bangladesh or from somewhere. But I want to make sure that you understand your responsibility. If you feel happy, if you feel competent to use them, do it. But personally, I feel we should stay away from using these medicines which have got potential side effects. So our learning lessons, I think, will be the premature ejaculation is very subjective. It depends on the perception of the couple. Second, we should not have any prejudice. We should not think that because of premature ejaculation, there is underlying cause which is maybe embarrassing for the people, and that could be a bad impression on the patient. Its main way to diagnose is taking history, examination, thorough examination, external genitalia, including external genitalia, and to make an diagnosis, and treatment through providing information, explanation about the premature ejaculation, and reassurance. Marriage and sexual counseling is very important. And if you have got any counseling available, you should refer this couple to them for their advice. And if we do that, we will achieve our mission for a happy, lovely life. And these are the people waiting in wings in their life. Whether they will come to you, I don't know, but this is the childhood we missed when we don't have the problem which you are talking it now. And last thing I would like you to take away, that we must find time to stop and thank the people who make a difference in our lives. Anybody in your life who contributed to your journey where you are now, your parents, teachers, patients, everybody should be thankful. And thank you for your time to listening to me.
Thank you, sir.
Yeah. Any question you have?
আদাব স্যার। স্যার, প্রিমেচিউর ইজাকুলেশন এবং ইরেকটাইল ডিসফাংশন দুইটাই যদি থাকে, সেক্ষেত্রে SSRI এবং ভাইগ্রা দুইটা কম্বাইনলি দেওয়া যাবে কিনা?
You can. SSRI and Viagra, they are not contraindicated. কিন্তু মুশকিল হলো যে SSRI আপনি কেন দিবেন, Viagra কেন দিবেন, এটা আপনাকে কনফার্ম করতে হবে for you. কারণ sometimes মনে করেন একটা পেশেন্ট, they have got depression and they're already taking medicine, SSRI medicine. এখানে আপনি যদি তার যদি erectile dysfunction থাকে, yes, you can give either Viagra or Cialis. Sometimes Cialis is, in my experience, I'm not saying this is, in my experience, Cialis is a good medicine for if there's a mixed problem with erectile dysfunction and premature ejaculation. Viagra can help, definitely it can help, but যদি আপনি every day, if you give 2.5 to 5 milligram every day Cialis, they have a steady blood flow. এবং আমার ব্যক্তিগত experience আমি দেখছি this is a good medicine. But going back to your question whether you can give it or not, but it depends on your clinical finding. যদি মনে করেন যে ডিপ্রেশন আছে এবং তার erectile dysfunction or premature ejaculation আছে, yes, you can give it.
স্যার, একটা জিনিস জানার জন্য, প্রিয়াফিজমের সার্জিক্যাল ট্রিটমেন্ট ছাড়া এমনি মেডিসিনের কোনো ট্রিটমেন্ট আছে কিনা?
আমি মেডিসিন ট্রিটমেন্ট অনেক সময় করে কি ইনক্রিজ ওয়াটার ইনটেক করে দ্যাট করে, অনেক সময় ইন্টারভিনাস ফ্লুইড দেয়, হ্যাঁ, কিন্তু অনেক সময় হয় কি যে ব্লাড ক্লট হয়ে যায়, যে the vein is blocked due to blood clot, and then that blood clot needs to be removed through the surgical. This is a very sad thing, but it can happen. কিন্তু
Yes.
এটা খুব একটা কমন না, কিন্তু আপনার প্রায়াপিজম যে কমন উইথ ভায়াগ্রা না, কিন্তু অত না, নর্মাল ন্যাচারালি কিন্তু প্রায়াপিজম হতে পারে। আপনারা জানি না, আপনারা পেয়েছেন কিনা, আমি দেখছি আমার লাইফে দুইটা কেস দেখছি, that's natural priapism. They had sexual intercourse and then the penis didn't come back to flaccid state, and then they required the treatment. Medicine treatment অনেক আছে, অনেক medicine treatment they try before going for surgery.
Yes, thank you, sir. Adab, sir.
Anybody? আপনাদের যদি কোশ্চেন না থাকে, then I would like to terminate the session. রিফা?
স্যার মনে হয় কোশ্চেন নাই কারো স্যার।
ওকে, তাহলে থ্যাংক ইউ। আমি এই লেকচারের পিডিএফ ফাইলটা পাঠিয়ে দেব, could you please share with the candidates?
স্যার আইটি আপা এটা ভালো বলতে পারবে। আমাদের হোয়াটসঅ্যাপ গ্রুপ আছে, ওইখানে দেওয়া যায়, অথবা অনেক সময় হচ্ছে পিজিসিএফএম এর ওয়েবসাইট থেকে আলাদা করে মেইল করেও দিয়ে দেয়।
আমি তাহলে লাবিবাকে পাঠিয়ে দেয়, or then she will share with the other people.
জি
স্যার এটা আমি ওয়েবসাইটে দিয়ে দিব।
আচ্ছা, থ্যাংক ইউ, দ্যাট উইল বি বেটার। তো আপনাদের সবাইকে অনেক 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 ধন্যবাদ এই সময়টুকু আসার জন্য, and to listen to this lecture, and I hope to meet you physically sometime. আমার খুব ইচ্ছা যে আপনাদের সবার সঙ্গে একবার দেখা হোক, but I will try. Thank you. Thanks.
একদম স্যার, মিটিংটা
থ্যাংক
শেষ
ইউ
করে
স্যার,
দিতে
ভালো
হবে।
থাকবেন।
Okay, sir. Adab, sir.
হ্যাঁ, ভালো থাকেন আপনারা সবাই। আর
Okay,
কোনো
sir.
যদি কোশ্চেন থাকে, প্লিজ সেন্ড দ্য কোশ্চেন টু মি, লাবিবা বা রিফাত, যে কোনো কাউকে দিলে they will forward to me, and I'll try my best to answer your questions.
ওকে স্যার, আমি এন্ডিং দ্য মিটিং।
Okay, thank you. Thanks.
Thank
End
you,
call.
sir.
হ্যাঁ, please. Thanks.